Hello, this is Mary Gavoni. Our program this evening is Infection Prevention in the Dental Hygiene Treatment Room. I'm sure that many of you have many questions, and I will tell you that I have many answers, but maybe not all of the answers to those questions. We are going to save questions until the end, and so if you put your question in the Q&A box, it should be at the bottom of your screen. And then we'll try to get to as many questions as we can. Please keep in mind, after we finish the program, Trung will give you some instructions for CE credit. And Viva Learning is the entity that can help you with your CE credit. As much as I would like to, I cannot. So let's get started. First of all, thank you very much to Premier for the sponsorship of this program this evening. We appreciate your support, and we also appreciate the many wonderful products that you bring to us in dentistry and in dental hygiene. So these are the things we're going to talk about tonight. Where are we now? What do we know in terms of how COVID-19 and the coronavirus is affecting what we're going to be doing, especially in our hygiene treatment rooms? What happens when we reopen for elective care? And I hope it's not chaos. I hope that we don't end up having some outbreaks of disease, but I think that depends on how well we can protect ourselves and our patients. Lots of you are questioning what standards, what guidelines do we follow, and I'll go through that. And then we need to look at what kind of concerns we have about safety in treating patients. Now, many of you have heard, and this is kind of the buzzword out there in the dental profession, will there be a new normal? Everybody says, yes, there'll be a new normal in dentistry, but not everything is changing. Yes, there will be some things that are different, but a lot of things will actually stay the same for us. And I want to highlight two really critical pieces of that right now, because I'm hearing from either emails or on other webinars that I've been presenting or in interacting with lots of folks that we're getting a lot of misinformation out there, in particular about disinfectants. So what I want to call your attention to are these two product labels. Now, first and foremost, this is not product bashing. This is just asking you to look at the labels and look at what I have listed here. I'm going to call this product A, although it's obvious what product it is. We've got a number of pathogens listed on the label. This label has to be approved by the Food and Drug Administration, cleared by the Food and Drug Administration to make the label claims that it kills these microorganisms. The EPA registers the product, and then the FDA clears the label. And so one of the things I've highlighted here for you is Mycobacterium tuberculosis on this particular product. Then we go to product B, the other label, and you see probably 5 or 6 times as many microorganisms listed here on this label. And I've highlighted one of them, of course, SARS-associated coronavirus. So based on this information, I want to ask you a question. And the question here is, based on the labels that you just saw, which product is the right choice for dentistry? Product A that had Mycobacterium tuberculosis highlighted, or product B that had the coronavirus highlighted? We'll give you all a little bit of time to respond. This is really creating lots of confusion for people right now. So I think this is a really, really important concept. Okay, we're going to wait just another minute here, and we have lots of you on tonight, so we want to make sure everybody gets a chance to weigh in their opinion. Okay, so I think we have a pretty good representative sample, and You can see the results here. That's almost evenly split. It's 48 for product A and 52% for product B. But the answer to the question is actually product A. And the reason for that is this. Just about anything can kill the SARS-CoV-2 virus that causes COVID. It's a very fragile virus. It's very easy to kill, but everybody's freaking out about how do we kill it. We need to be more concerned about how do we stop it from spreading. So this slide here shows you a representation of the hierarchy of the resistance of microorganisms to disinfectants. Most resistant are prions, which actually are not microorganisms, they're bits of protein. Spores, Mycobacterium, and Mycobacterium tuberculosis is a spore-forming bacteria. All the way at the bottom are enveloped viruses, which is where SARS virus and SARS-CoV-2 fit in. Remember that the CDC infection prevention guidelines for dentistry say that we should be using a hospital-grade, intermediate level disinfectant that makes a tuberculocidal kill claim. So that's why we don't need to worry about whether or not our disinfecting product that we're using actually makes a kill claim for COVID. First of all, because this is a new virus, it may not even have had a label change approved or cleared yet by the FDA to make that. But what you may see on some labels is it will say it's effective against SARS. Excuse me, it's effective against SARS. It may have a kill claim for human coronavirus, or some will say it has a kill claim for emerging pathogens, which could include coronavirus. So don't freak out and don't change your disinfectant because it doesn't say it kills COVID on the label, but some product representatives are telling people that other products don't work because they don't say it kills COVID on the label. What you really need to look for again is that TB kill claim. Now, the other thing that is going to stay the same for us is, excuse me one more time, bad allergy day, not COVID. The other thing that's going to stay the same for us is sterilization protocols. Instruments, multiple use items, all remain the same. We clean, we rinse, we dry, we package, we sterilize them. The one thing that I still see some misunderstanding about, though, is handpieces. If you have slow speed handpieces that are connected to the dental unit air and water lines, every piece of that handpiece must be sterilized after each use, according to CDC. CDC goes as far as to say if those handpieces and the motors, everything cannot be heat sterilized, they shouldn't be used. And many people are of the understanding that it's just the prophy angle and the attachments, the nose cone perhaps, but not the motor. Motors need to be heat sterilized as well as other items that might be attached to the air water line. So a holder for an ultrasonic scaler, it could be an air polishing device, anything that's attached to the air and water lines. Now, if you use cordless handpieces, which especially from an ergonomic standpoint, I love to recommend because number one, we don't have the tug of the cord and they are not attached to the dental unit water lines. And so they don't fall into that sterilization category unless whatever handpiece you're using may have some pieces that detach and can be and must be heat sterilized. It depends on how your cordless handpiece is made. And then you also can get sleeves. shown here on the AeroPro handpiece that you can put over your handpiece to prevent contamination of some of the controls. So that's not a change because of COVID. That's been in effect for a very long time, but sometimes is overlooked. So those two things, sterilization, disinfection, essentially stay the same. Now we're going to talk about not only what's going to change, but why. Why does it need to change? Well, here's where we know, or where we're at, what we know about the SARS-CoV-2 virus or the coronavirus at this time. Asymptomatic or pre-symptomatic individuals may be infectious. They also may not know that they're infectious. And recent studies that have come out have shown that they may be the most infectious individuals that we might encounter. So even though we might be screening patients for symptoms, a dry cough, a fever, and so forth, they may have been exposed, they may not know it, they may be infectious, and they may be very infectious because they tend to have the high-risk viral load before their symptoms occur. So that could be a challenge. And the biggest challenge is that we don't know who those people are. It could be any of us. I just heard this afternoon that one of my consultant colleagues knows a dentist who has COVID and is critically ill in the hospital, may have treated a patient, didn't realize the patient was infectious. So this is real, and everybody's anxious to go back to work in some cases, but many people are concerned about what to do and how to protect themselves. So according to the CDC, we have to treat all patients, all individuals, as if they're infectious for COVID-19. That's the same language, the same thing that we've known all along about practicing standard precautions, that we treat all of our patients as if they're potentially infectious for HIV, hepatitis B, hepatitis C, and we don't take prisoners, we don't make exceptions, we don't necessarily rely solely on what we know from their health history. Sorry. Very sorry, didn't mean to make my phone ring. I thought I had it on mute. So standard precautions means that we do the same thing for every single patient because we don't know if they're infectious or not. But just like in the CDC guidelines from all the way back to 2003, the CDC believes that our typical respiratory protection that we would wear, a level 1, 2, or 3 surgical mask, is not sufficient to protect us from COVID-19. It's also not sufficient to protect us from tuberculosis. So we've known that for a long time. So in that instance, or in that situation, it's not changed. The other thing we know about the SARS-CoV-2 virus is that aerosols from dentistry can remain airborne for up to 3 hours. So that has huge implications for us in scheduling. If we don't have appropriate mitigation air filtration systems in treatment rooms, then we can continue to be at risk from the aerosols. Other people in the practice can be, including patients. And the SARS-CoV-2 virus has been found in these aerosols. Now, you also may have heard, and it is true from all the research that's been done about this coronavirus, is that most of the infections that take place, or the transmissions that take place, come from larger sized droplets. And those droplets are heavier than the aerosol. So they are probably not staying airborne for up to 3 hours. They're going to settle out of that aerosol onto surfaces. But if there are coronavirus particles in the air, the small ones that are less than a micron that are in those aerosols, those are the really dangerous ones, because those are the ones that are able to get in to the lungs. So we need to look at, how do we control that? How do we make this effective? So I want to go through sort of quickly a few things about reopening your practice for elective care. Many of you are either on the verge or starting to plan for it now. So I encourage you to make sure that you have a conversation with the entire team. The entire team needs to be together and meet, whether it's virtually, and I know a lot of teams that are meeting over Zoom or they're FaceTiming or whatever it takes to meet remotely to talk about what this is going to look like. And then you need to have a plan so that patients don't get confused when nobody really knows what it is that we need to do. So the most important conversation that you need to have starts with, do we have PPE? Some of you were experiencing extreme shortages just before we closed our practices down. So do you have some? Do you have the right PPE? And we'll talk about what that means. And do you have enough? We are not going to be going back into our practices and just flipping the switch, turning the lights on, turning the vacuum pump, turning the air compressor on, and just going back to seeing patients as normal in the same kind of schedule as we normally would. We can't do it because we probably don't have enough PPE at this point. Every dentist that I have talked to in the last couple of weeks has been spending most of their day going out trying to procure masks, trying to get disposable gowns. And so if you don't have the right PPE, you're not ready to see patients. But the teams also need to know, employers especially need to know, is the team confident or are they fearful? Now, I think we're all a little bit fearful right now because there's so many unknowns, but everybody needs to express their true feelings, in my opinion, so that employers and coworkers understand what everyone is thinking. Because if you have some irrational fears, perhaps those can be calmed. Perhaps some information and some logic will help someone or help you to feel better. Perhaps some of you haven't thought about what some of the risks are. So we need to share that information, because if everybody on the team isn't on the same page when we start to see patients on a more regular basis, patients will sense that, and we need to instill in our patients a sense of confidence in what we're doing and that your dental practice is a safe place for them to come. The other thing that I think is not really discussed a lot, but it should be, consider the liability to a practice if somebody contracts COVID-19 because they work in the practice, maybe without the right personal protective equipment. What if the doctor gets sick? What if a patient gets sick as a result of treatment because they were exposed perhaps to aerosol from the previous patient? Many malpractice insurance carriers right now are asking doctors to look at their consent for treatments. And so you should all contact your insurance carrier and find out what it is they recommend, that you have some type of a disclaimer that hopefully helps you in the case that your patient perhaps didn't disclose their status or symptoms correctly. So it's something that, you know, in our haste to want to open back up and get revenue coming back in, we don't think about. We may be better off waiting a little bit longer, having a better plan to get started. So this is my mantra. Just because your state says you can reopen the practice doesn't necessarily mean that you should. And some of you have probably already found the typo on my slide. So think about that. Are you really ready? Then the other thing to remember is that many of the precautions that we're going to be taking, wearing perhaps N95 masks or KN95 masks and face shields and disposable gowns, may be temporary until we get past the pandemic. And I think we're forgetting that we're still in the middle of this pandemic. So it's not going to be life as usual in terms of PPE when we go back into the practice. So on Monday this week, the American Dental Association released this amazing document, very well done, very well planned out, that is a toolkit that you can access on the ADA website for helping you to make your plan to go back to work, to get everything set up that you need to. There's a couple of things that I want to point out that are in the toolkit though, and I don't mean this in any way as a disrespect for the American Dental Association. They have their reasons for why they have said what they've said, but I've consulted with a lot of the experts that I work with, and I have two things to say. One is, if you look at the information about protecting the staff, and they talk about using N95 masks, they will tell you in that document that OSHA has suspended its requirement for fit testing of N95 face masks. And I'll explain it in a bit what fit testing means. But the reality is that OSHA has said that they have suspended only the annual fit testing that's required, something we haven't really had to deal with in dentistry before this, but they have not suspended initial fit testing. So I'll come back to that. So just put that in the back of your mind. And the other thing is, there are many forms in this toolkit, one of which is a form that you can use to record the temperatures of the team members. Remember that the CDC interim guidance says that all the employees should be screened. They talk about doing it before you even enter the facility. I don't know that we need to make people wait outside the door to have their temperature screened, but as soon as they come in, they should be scanned with a non-contact thermometer and temperatures recorded. But employment laws say that any kind of medical information, including asking employees about symptoms or doing self-checks, self-assessments for risk of their own infection, cannot be common public information. It's considered to be confidential. So either that has to be recorded in a confidential file for each individual employee that then is kept in a secure area, or you have to find some other way to do that recording because it can't be public information. Other than that, I think that this is an excellent, excellent blueprint for you to be able to utilize in the practice. These two documents are an absolute must for you to have in your practice. One is the interim infection prevention and control guidance during COVID-19 from the CDC. And it is interim, so again, temporary. We don't believe that this is going to be in effect forever. We have to wait and see how this virus runs its course. And this other document is from OSHA, Preparing Workplaces for COVID-19. In this document from OSHA, which came out last month, dental practices have been classified as the very highest risk settings for transmitting COVID-19 because of the aerosol, in combination with the fact that we don't know who all is infectious. This is another resource that comes from OSHA, and it talks about high exposure risk settings. And again, at the very top of this triangle, I know this is a little hard to see, this is where dentistry is right now. So we need to be wearing appropriate PPE. This is some highlights from the update to the CDC interim guidance that came out this past Monday as well. So we're still talking about postponing elective procedures, surgeries, and non-urgent dental visits. That's what the CDC is currently saying. So that may be in conflict then with some of the states that are saying dental practices can open up again. And you're going to have to deal with that on an individual practice, on an individual state basis. So you need to also have policies, the stay at home if you're sick policies, making sure that if any employee has any respiratory symptoms or a fever, if you take their temperature when they report for work and it's 100 0.4 or higher, they need to be sent home. And we don't see patients. We're also going to be screening patients, taking their temperatures when they come in to the office. This is why you need to have a plan ready. And then you need to know what to do if a patient does come into your facility that has some symptoms. They have a temperature and so forth. We need to get them a face mask. We need to get them isolated so that they don't spread. And we, again, need to start actively screening everyone coming into the facility. So this could mean your sales reps, your Shine, your Patterson, your Benco rep come into your facility. They should wear a face mask and you should be taking their temperature. And if it's above 100.4, then you need to reschedule them. I honestly think that we should look at least temporarily, not doing in-person visits from our vendors, that we do them over Zoom, we use Skype, or we use some kind of a virtual platform to talk to our vendors. So it reduces their risk of exposure and it reduces your risk of exposure as well. So these are the CDC sort of hierarchy guidelines that were published by the ADA about face masks. And so the key here is that what we want you to do, because we will be producing some aerosols, is wear the masks that reduce the risk to very low, which means N95 or KN95. KN95 is the equivalent of an N95 mask, but this is a Chinese standard or a Chinese designation that is not FDA cleared, but has been cleared for use by the FDA and the CDC under what's called an emergency use authorization. So the FDA says it's okay and CDC says it's okay to use these because the N95s are in such short supply. If they were in good supply, readily accessible, the FDA probably would not have made this emergency use authorization for these masks because they haven't been tested by our standards. Then what you normally would wear before COVID would have been a surgical mask, a procedure mask, and they provide only moderate protection. And that has to do with the fact that the mask doesn't seal. The N95 and the KN95 masks form a good seal around your face. The barrier protection, the particle filtration, is relatively the same. But if you have gaps on the side or the top or the bottom of your mask, aerosolized particles can get in and you can breathe them in. They can get into your lungs. So that's why, that's the rationale behind the N95 masks. So I mentioned before that I would talk about fit testing of N95 respirators. So OSHA requires that if you wear N95 respirators, they need to be fit tested initially and annually. As I said before, OSHA has waived the annual requirement, but the other requirements are in place. First and foremost, everyone should fill out a medical questionnaire, and there is one available from OSHA. And I'll explain to you when we're done how you can get some of this information very easily. If somebody has some underlying conditions, circulatory problems or breathing problems, maybe somebody has COPD or perhaps they've got asthma, they may not be able to wear an N95 respirator because they may not get adequate amounts of oxygen. And if you've tried on an N95, you know that it's very difficult in many cases to breathe in those respirators. So what we don't want to do is exacerbate anybody's underlying health problems. So if you want, there should be available a copy of this presentation in PDF format, and all the links that I've put into the presentation will be active, including this one, which is a YouTube video which shows how to do fit testing. Now, this test that I'm showing here on the slide is called a qualitative test. You can be trained to do this. There's no special certification that you have to have. So somebody who's the OSHA coordinator, the infection control coordinator, or the employer could do these for employees, or you can go to an occupational medical center. Some consultants are available in certain areas, industrial consultants that can do these, but you could easily do, especially your initial and annual ones, in your practice. So you go and select what you believe is the right size of face mask. The N95 respirators are size specific. You put it on. You do what's called a seal check, which is to place both of your hands over the mask and sort of push on it lightly, and then exhale and see if you feel any air leaking around it. If you don't, then you might have the right mask. You probably have the right size mask. Then there's a hood that's placed over your head, and there's a solution that's introduced into this hood. And some test kits have a bitter tasting solution, bitter smelling solution. Some have a sweet smelling solution. If you can't smell it or taste it, then your mask is appropriately sized and sealed. If you can, then you need to start over with a different mask. And that's basically how fit testing is done. So again, OSHA has not waived this. I don't know how we're going to be able to deal with this right now because these fit test kits are not available. I actually have them on order from 6 different companies right now. They're all on back order. So whether or not you're able to even get a test kit, there are resources available to get the training to be able to do them. But again, make sure first and foremost, the employees all fill out the medical questionnaire if you're going to wear N95 masks. And if you see answers to the questions about breathing issues and so forth, then they need to have a medical exam. Now, the other thing that we're seeing in the CDC guidelines, and OSHA is saying the same thing, is that we should be wearing chin length face shields. These can then serve as our eye protection, and they help to prevent contamination on the mask. So as these masks are in short supply, a way to preserve the masks, if you're going to wear an N95 or a KN95, is to wear a face shield. And some people are also choosing to put a level 3 surgical mask over the top of that KN95 or the N95 to also prevent it from contamination. And then you don't have to change that N95 or KN95 after every patient. The challenges, though, are what will fit over loops, what will fit over a light, and who actually has chin length face shields available. I think as we go forward that OSHA most likely, although this isn't gospel, but I think they most likely will require us to continue to wear face shields because it does make it safer for us from spatter and splatter, and there is some aerosol protection for us. Then this is the big controversy in the CDC documents: gowns. Now, keep in mind that OSHA in the bloodborne pathogen standard has always required us to wear a gown when we're producing aerosol, spatter, or splatter. So you pick up a handpiece, you pick up an ultrasonic scaler, you use an air water syringe, you should be having a long sleeve gown on. Many practices ignore it because employees get warm and they wear short sleeve scrubs, but that is an OSHA violation. Now, the change from the CDC interim guidance is that they need to be changed after every patient. Otherwise, you're going to be potentially cross-contaminating with droplets on that clothing. So you can use disposable. These, in some cases, are referred to as isolation gowns, or you can use reusable lab coats, scrub jackets that can be laundered on site, but they cannot be taken home. That also is an OSHA rule that's been in effect from the bloodborne pathogen standard since the early 90s. So you have choices, either disposable or reusable. But CDC also says that they must be removed before you leave the treatment room. So you can't go from one point to another with that contaminated gown on. Now, I know there's some logistical things that have to do with hygiene evaluations. What are we going to do? And we don't really know. We don't have all the answers to those questions yet, which is why I think we're really not quite ready to start to see patients again. Now, the CDC guidelines also talk about head covers and shoe covers. They are not mandated. OSHA does not yet require us to wear them. They haven't required us to wear them historically. I think head covers or bonnets are a great idea because especially if you're scaling, you know that you get debris. I can remember when I was doing clinical hygiene and I did a debridement on a patient, there would be times I'd go home and pick calculus out of my hair when I went into the shower. So that I think is a good suggestion. I have mixed feelings about shoe covers, but we're going to have to wait and see whether OSHA requires us to wear them or not. At this point, it's a recommendation. So I'm not going to spend too much time on these next couple of slides because I really want to get to the hygiene specific information, but just some suggestions for getting the office ready to see patients. Get the magazines and the toys temporarily out of the reception area because you can't disinfect them. Close down your beverage centers and coffee bars, especially that so much time now has been designing these beautiful areas for patients for hospitality. No water in the fridge. You just put a sign on it that it's not available right now. You may have to space out the chairs in the reception area because CDC, remember, is still suggesting 6-foot social distancing. And so we're going to have less people in the reception area at a time. And this is an example of a sneeze guard. Yeah, let me go back. That you may want to have at the front desk for added protection for the team members, the admin team members at the front desk. And you should have a hand hygiene station. Either have hand sanitizer and you ask your patients as soon as they come in the door to clean their hands, or they go to the restroom to wash their hands when they come in the office. Then again, sneeze guards for the front desk, masks for the administrative team members. Teledentistry is becoming very popular, ways to communicate with patients, to help in screening, to help reduce the number of visits a patient may have to make if they just have a question that could be dealt with. And you need to make sure that you have prepared screening protocols so that before their patient comes in for the appointment and we're asking them the appropriate questions so that we can tell people if they have any risk of exposure, if they have a fever, if they have respiratory symptoms, we don't see them. And I hope that stays in effect forever. Don't let the sick people come in. It may not be COVID, it might be flu, might be just a cold, but why would we gift it to everyone? And then we need to screen patients on arrival, again, by taking their temperatures. So whether or not you're involved in the clinical areas, but this is just, again, a short list of things to get ready. And you're going to have to do at least the water system shock and testing about a week ahead of time. So some of you may need to be doing that now if you're getting ready to open. Follow the manufacturer's instructions for the products you use, for the equipment that you have. Make sure that you spore test your sterilizer before you start seeing patients again, and validate it with a type 5 integrator that you put in the load, because you may not get your spore test results for several days, but you'll get an immediate readout from a type 5 integrator. Then make sure everything else is working right. Compressor, vacuum, amalgam separator, any other equipment. If it's been shut down for a while, make sure it's up and running. So now let's go into the hygiene room. And this applies in the other operatories as well. First and foremost, get the clutter off the countertops. It will become contaminated with droplets and from that aerosol. So non-essential items, Lots of people have their family photos and lots of tchotchke stuff on the counters. Get them out of there. And other types of items that you might use during treatment either need to be in covered containers or in cabinets or drawers, or store them outside the room. They shouldn't be on the countertops. I would even be careful about how you store your gloves. Many practices have either dispensers on the wall with openings to pull the gloves out, or they sit boxes of gloves on the countertop, and the droplets can most certainly be contaminating those gloves when we're using hand pieces and so forth. Then take a look around the treatment room on your equipment, around your dental units, lights, and so forth, and see what kinds of barriers could we use if we don't already. And I understand a lot of people are concerned about using barriers because we're sending lots of stuff to the landfill. And, you know, I want to be as environmentally conscious as I can, but sometimes the barrier is the best option. And something we haven't really thought about a lot, but I think we need to, and we have a good option to help us with that, is what about applicator tubes for things like sealants or fluoride varnish? You can see these sleeve it devices, these are from Premier, that you can put over these dispensers so that when you're done, all you have to do is remove the barrier and you don't have to worry about disinfecting every single one of the tubes or applicators that you have used if they're multi-dose products. So this is a good option to using single dose products, which of course then send more waste to the landfill. This way you can easily protect them from contamination. These are like my new favorite things. So then once we've looked at the environment in terms of surfaces and equipment, then we need to look at how are we going to control some of the aerosol. So if you read the CDC interim guidance, it says limit the use of hand pieces, limit aerosol production, and use of ultrasonic scalers is not recommended. And I'm sure that there is a collective groan going on right now from all the hygienists in our audience, because going back to only hand scaling on patients is probably invoking some nightmares right now. I suffered from carpal tunnel syndrome when I was doing clinical hygiene because I worked in a practice where we could not use ultrasonic scalers. And so I would never want to go back to the days of only hand scaling. But keep in mind that as far as we know, this is temporary. I don't believe that you'll never be able to use an ultrasonic scaler ever again. But right now, when we're still in the middle of the pandemic, we still have lots of new cases. We don't have testing available to know who's infectious and who's not. Pretty risky proposition using an ultrasonic scaler. But we do have some devices available that we could use to help control aerosol, perhaps from polishing, or if you had to do maybe some limited scaling with an ultrasonic or a piezo scaler, but I still wouldn't recommend it. So what I'm showing here are some devices. Now, there are a lot of other devices, suction devices, that are available for hygiene, geared toward hygiene, that connect to the saliva ejector or low volume evacuation system. I would not recommend those at this time. They're great products. I'm not saying they don't work, but right now we need to look at everything we can use with high volume evacuation to make sure that we are reducing the aerosol as much as we can. So we have Mr. Thirsty from Zerk. We have Isovac from Xyrus Dental. And this is a relatively new product on the market from a company called Afflex, and this was invented by a hygienist. And it was originally designed with this arm that attaches to the back of the chair to hold the saliva ejector. But they've now adapted it so that it can connect to the high volume evacuation, and it has this autoclavable cup at the top that you position near the patient's mouth. So this won't reduce all the aerosol, but it reduces a lot of it. This particular device at the bottom here is not available yet in the US, but I think it will be relatively soon. It's from Spain, and it's pretty cool. It does lip and cheek retraction, and then this area right here that sits just below the teeth is high volume suction. So I'm sure there will be more. There'll be lots more things that come out on the market that can help us reduce the aerosol, because the aerosol control is not just important now in this time of the COVID pandemic. It is of great concern for any kind of aerosols, whether it's from removing amalgam restorations or whether there's colds or flu viruses circulating around. We need to be careful. Now, the one thing you may have heard a lot about lately is extraoral evacuation. And I have to tell you, my personal opinion is, I think this is the way to go in the doctor's treatment rooms, in the hygiene treatment rooms. And I'm secretly hoping that this may become some type of a directive from OSHA, or that we have to look at our HVAC systems and air exchanges in our treatment rooms. There's also a lot of talk about air filtration and air purification, but this is the National Air Filtration Association that says that right now there isn't any scientific evidence that proves that these devices that are available can remove COVID, SARS-CoV-2 particles from the air, but they can help. They can help remove aerosols. They can help improve air quality. That's a good thing. Just be careful of some of the marketing claims that some of these companies are making that say they're certified to kill COVID. That certification should be coming from the National Institute for Occupational Safety and Health, and I don't see too many of those that are actually NIOSH certified. So that's one of those buyer beware things, but it doesn't hurt. Some of them have UV light. There's lots of products available, but you have to weigh the benefit versus the cost. Now, having said that, this particular device is from a company called ADS Dental. This is not inexpensive. It's about $2,500, give or take, but you can see the difference in how it focuses and removes that aerosol. Directly removing the aerosol, not waiting for it to circulate around the room and then go through an air filtration system, which is why I'm in favor of this. Okay, so I want to get to questions because we have lots of them. What I want to tell you is I have told you about a lot of different resources and lots of things that are available. And to save you some time, if you would like to take advantage, if you click this link, maybe screenshot it, it'll be on the handout. And this is on my personal website, and you use the code VIVA. If you decide you would like to have this resource manual, all of this information I've talked about, and then some research articles, OSHA standards, CDC guidelines, more information than you could ever imagine is there. So with your coupon, you will see that it is available to you with that code for only $10. So that's my sales pitch. I don't want to go any further into that, but I just want to let you know that that's available for you. It could save you lots of time and trouble trying to locate lots of different resources. This is my contact information. You might want to screenshot this as well. If you have questions that we don't get to before we run out of time this evening, you are more than welcome to email me with your questions. Just please put Viva in the subject line so that I know you're not a spammer, because I wouldn't necessarily recognize your email address. So I'm going to turn this back over and we are going to go to Q&A. Trung, do you have any instructions for our participants?
No, they can send you questions via their application, the Zoom
Okay,
application. Yeah.
and I just need to go back and get my Q&A view here. Come on back. Okay, so I'm going to take these questions. And again, we may not get to all of them. So one question we have is, ideally, wouldn't we want a product, and I'm assuming this means a disinfecting product, that would kill both? Yes, we would want a product that would kill both, but if a product doesn't specifically name COVID on the label, that doesn't mean the product doesn't kill it. Remember the hierarchy, and the reason that we use Mycobacterium tuberculosis as our benchmark microorganism to the gold standard for our disinfecting products in our practices is that it kills some of the most difficult to kill, which means that it also kills those that are the easiest to kill. So my concern is that people may make the choice of a product that says it kills COVID or says it kills SARS, and it doesn't make that TB kill claim, so it may not be killing other more difficult microorganisms. So I don't think that's so important. Yeah, and I see a couple of questions on here about the CRA report and some things that have been said, and I think that that's a choice that you have to make. The Food and Drug Administration and the CDC have said that the products we have that make a TB kill claim are effective, and I don't think we need to worry about that. How can we stress to the doctor the importance of sterilizing Prophy handpiece that is attachable to the, well, I think you need to show the doctor the copy of the CDC guidelines. And then keep in mind the liability from not following CDC guidelines, because if anyone ever claimed that they contracted COVID in your practice or any infectious disease and you weren't following all the CDC guidelines, it's possible that your liability insurance wouldn't cover any kind of claims. Not to mention that now in this era of hyper sensitivity and patients being much more discerning about infection control, that just wouldn't be a good thing. You need to make sure that that you're at the top of your game and make sure your patients feel safe. So another question is there a reason why I didn't mention the EPA list N? And that is the list of all the products that say they kill SARS-CoV-2 or COVID or coronavirus. I didn't specifically because this, again, is my concern, as I think I said earlier, that people are going to get so hung up on whether or not a disinfectant is on the list N or not. Just because it's not on the list N today doesn't mean that the product manufacturer isn't already in the process of getting their label cleared by the FDA. And I don't think it's appropriate to rely just on the SARS kill claim when that is one of the easiest microorganisms to kill, because we are still held to the CDC guidelines that say Mycobacterium tuberculosis. And some of you are probably thinking, yeah, but it's not OSHA, it's just a guideline. Think again, because most of your state dental practice acts say that you must follow CDC guidelines. So I'm not overlooking list N. I just don't want everybody to get their undies in a bundle about it, because it's not as critical, in my view, as the tuberculosidal kill claim. Great question. What about hygienists that are older than 60, 65, 70? How can dentists employ them confidently and not expose them? Well, what we heard in the beginning was that the COVID virus, the people who were most susceptible to the COVID virus were people who were elderly, who were over 60. I'm in that category. But what we found, though, is that the hospitalizations that we're seeing now for serious symptoms are in much younger people, even children, young children. A 5-year-old girl in Michigan died from COVID. So it really depends, I think, not so much on age, but underlying conditions, whether somebody has asthma or diabetes or high blood pressure. And of course, the high blood pressure, diabetes are a couple of the things that are hitting our African American communities so bad, putting them more at risk for COVID. So I don't know that it's such an age thing. And employers are required to provide a workplace safe from known hazards. COVID is one for all employees. It doesn't matter what their age. We don't make it safer for one group than another. I've always been a team of one when it came down to not wearing scrubs to the office as well as work shoes and leaving them there for the dentist to be responsible for the cost of laundering them. What is your opinion on this? I think we talked about this already. Many practices were not compliant with the OSHA requirements before COVID, and it's not a good thing. You could have taken flu or cold viruses, which interestingly enough are also coronaviruses, home on your clothing. OSHA specifically says in the bloodborne pathogens standard that when there is potential for splatter, splash, or aerosol, protective clothing must be worn, and that is over scrubs. Scrubs are not the protective clothing, and that those contaminated items should not be worn out of the office. So if you wore your scrubs in the office all day and you wore them home, you're in double violation because you wore contaminated clothing home and you didn't have protective clothing over the scrubs. And I certainly wouldn't go home in my scrubs and hug my kids. Not a good idea. So I think a lot of people now are trying to find gowns because they've never worn them before, but they should have been wearing them all along. Is the amount of time that aerosols stay suspended different when using HVE and when not using HVE? That is an excellent question. And I don't know that I've ever seen that addressed in any of the aerosol studies. I believe that because we don't trap all of the aerosol, we don't control it all with just an HVE intraoral, that the aerosol is going to be in the air, and it doesn't matter whether we're using an intraoral device. That's why OSHA is really looking at those extraoral devices. The other option that OSHA mentions is negative pressure rooms, which would be very difficult to do in a dental practice. If we can use masks and shields for multiple patients, why not gowns too? How are exams done? Well, I don't have a really good answer for that question. Your face shield certainly needs to be disinfected after every patient, but don't use your surface disinfectant on your reusable face shield. Wash it with soap and water and then finish with a wipe of a lens cleaner or a gauze saturated in alcohol, because it'll dry it, it won't be spotted. The typical surface disinfectants will start to cloud up or gum up the plastic. Your face mask can only be worn on multiple patients if it is covered with a face shield. Otherwise, your mask must be removed in that treatment room. The gowns that requirement of the gowns being changed after every patient is something that OSHA wanted way back in the days of the bloodborne pathogen standard. And we meaning organized dentistry, argued against it. And so they allowed us to wear them, and the CDC guidelines before the interim COVID guidelines have said that we could wear it till it becomes visibly soiled. But right now, because of the ease of transmission of COVID from droplets, we're told change the gowns after every patient. And remember, I said, I don't know, and I don't believe that will be forever, but we just don't know that for sure yet. Okay, you guys have great questions. I think this is a question and a statement. Dental offices are really high in transmitting COVID, and hopefully I didn't misinterpret that. Dental offices are at a high risk for transmitting COVID. We don't know because testing hasn't been available. We don't really have any data that shows whether or not there are a high number of people who were exposed to COVID before we started shutting down. So we don't know the answer to that yet, but we certainly are at high risk because of the aerosols. So we're at 7 o'clock right now. We're going to go for just a few more minutes if we are allowed to, and take a few more questions because you've got some great ones here.
Yep, go ahead.
Okay, so did I mean that the dental personnel are at very high risk? Yes, I did mean that the dental personnel are at high risk of contracting, but we are also at high risk of transmitting, because think about what we talked about, aerosols. Aerosol, which could have COVID in it if you have an infectious patient and you don't know it, can stay in the air for 3 hours. Okay, and remember, it's the small aerosol particles that get down into the lungs. So I treat a patient, I use my ultrasonic scaler, I treat a patient, I'm finished with them in an hour, I clean up my room, take off my PPE, do all the things I normally do, and then I go and I bring another patient back in within 5 to 10 minutes of when I just finished my last patient. Now, if I haven't had some extra way to mitigate that aerosol, there is potential for that next patient to breathe in that aerosol. You're most likely protected because you have your PPE on, but the patient is not. That is the whole reason why we were directed to close, so that we wouldn't be transmitting that aerosol, transmitting that virus to patients. That's the whole reason behind it. So we need to think about what the potential risk is. So I think somebody asked a question about UPS or the post office. I think anybody that comes into your office, whether it's FedEx, UPS, mail carrier, whatever, take their temperature, ask them to sanitize their hands when they come into your office. Staying at home if you have symptoms. If you have upper respiratory symptoms after working a while and you're not sure if it's allergies or virus. Bottom line is, if you have upper respiratory symptoms, take your temperature at home. If you don't have a fever, you might want to consult your physician and see. Hopefully at some point we'll be able to do some testing so that if we knew that you just had allergies and not a COVID infection, you could be working. But right now, what the CDC is recommending is that if you have respiratory symptoms, that you not be at work, because we don't know, because we're not able to test everybody right now. The difference between the N95 and the KN95, I think we talked about. Remember, the N95 is an FDA cleared, NIOSH certified mask in the US. KN95 is a different standard from China, and it hasn't been FDA cleared, but under emergency use authorization, we're allowed to use them because we don't have, in many cases, access to N95s. Somebody's asking the question about the key concepts. I think that was one of the shields. Email me after and I'll give you some resources, because, or you're just going to have to go do a web search, because I could give you a resource now, but they may not have them in stock. So just use that key concepts and do a web search and you should be able to find it. So somebody says that they tried an N95 mask, they can't breathe. What else can you use? We talked about KN95. That's an alternative. They are a little bit more breathable for you. Let's see. Where does the ADS evacuation system expire the exhaust? They have a filtration system with UV light inside it. So you'd have to go to the product information for that particular device. This is a great question too. Do I recommend using a pre-treatment mouth rinse? And this has been discussed a lot. The recommendations that we had initially that came from ADA said 1% hydrogen peroxide or a povidone iodine rinse. I would run away from an iodine rinse for fear that I may find out that I have patients that have iodine allergies, and it's not going to, I haven't seen any preparations of that are flavored. The 1% hydrogen peroxide, just the hydrogen peroxide diluted out of the bottle is also going to taste horrible, but you've got Peroxyl and you've got Listerine whitening that have 1.5% hydrogen peroxide. But think about this. The COVID viral particles are in the lungs. When we talk, when we cough, when we sneeze, some of those particles come up from the lungs, they're in the saliva. So I do a pre-procedural mouth rinse. I've most likely cleared the virus from that one incident of coughing, sneezing, whatever. The next time I take a breath, there's viral particles back again. So there's not a lot of science. The whole science of this was based on the fact that the virus is susceptible to oxygenation. But beyond the first rinse and the next breath, then there's more particles. So it's not a long-term solution. Okay.
One more question, please.
I'm sorry?
Just one more question, please.
Okay. All right. So assuming that we need to change scrub caps between patients, I would say yes to that. So it looks like we have so many more questions and we don't have time to get to them, but I will tell you again that if you email me and ask your specific question, again, put Viva in the subject line, I will be happy to answer those questions. I may live to regret that, but I will answer all of your questions. I may not get to them all tonight, but I will do that first thing tomorrow. So announcements for the end. Thank you all for participating. Thank you again to Premier for sponsoring this educational event.